Good morning, everybody, and welcome to our webinar with Professor James Ward, Living in a New COVID World, Citizenship, Community and Responsibility. We're very fortunate to have Professor James Ward with us today, especially in NAIDOC Week and especially with the theme of healing communities. I'd now like to hand over to Gordon Browning to do acknowledgement.
Good morning, everyone. I would just like to acknowledge the traditional custodians of the lands in which we work and live, and pay my respects to their elders past, present and emerging. I'd also like to pay my respects to the Turrbal people and the people in Brisbane, where Professor James Ward's presenting from, the Turrbal people to the north of us, the Byerley people, the Trabelang Bunda people, and the Gurangurung people, and the country that we're on today is the Gubbi Gubbi people also. I'd sort of like to pay respects to them and to wherever you're coming from. Also pay my respects to you and your countries. Thank you.
Thank you, Gordon. So Professor James Ward is a Pitjantjatjara and Narungga man, an infectious disease epidemiologist and a national leader in Aboriginal and Torres Strait Islander research. He is currently the director of the Poche Centre for Indigenous Health in the University of Queensland. His work has influenced policy and practice, significantly contributing. Can we have everybody on mute, please, who's on the line? Thank you. So James's work has influenced policy and practice, significantly contributing to national guidelines, policy and practice. During 2020, he has contributed to the national COVID-19 response through the membership of Communicable Diseases Network of Australia and the National Aboriginal and Torres Strait Islander COVID-19 Task Force. I'm now going to hand over to James, and thank you so much for being with us today.
Thank you. Okay, is that good? Everyone can see? No?
Beautiful.
Yes, thank you.
Yep. Oh, great, thanks. Yeah. So thanks very much, Patty, and thank you, Gordon, for acknowledgement of country. Yeah, let me begin by also acknowledging the traditional custodians of the land where I'm sitting today in Brisbane, the Jagera and the Turrbal peoples, for their custodianship of country and waterways here in Brisbane for many thousands of years, and acknowledge that these places were always regions of learning. Let me also acknowledge the traditional custodians of the land wherever you're sitting today, and acknowledge their custodianship, and also acknowledge our emerging leaders. The theme of this week's NAIDOC Week is Healing Country, and I guess there's an intimate and direct connection and association with being healthy, being on healthy country and having healthy country and health status. So it really is a great pleasure to be presenting for you today about COVID and where we're up to and what we need to do better as we move forward with the COVID response, particularly in Aboriginal and Torres Strait Islander communities. I'd just like to acknowledge some people who've helped with this presentation, particularly in the show, the Indigenous area of the Commonwealth Department of Health, who've provided some of the data today, the Aboriginal and Torres Strait Islander Task Force, the National Centre for Immunisation Research Surveillance have also provided some of the data, and Christy Crooks, who's a PhD candidate and from an Aboriginal woman from Tamworth, who we've been working closely together during this pandemic response. So as Patty said, I've been working on COVID since really we started getting going in Australia, and I have been working on it predominantly at the committee level, but also running some small research projects on COVID around messaging and also impact on health service delivery with IUI, the Institute for Urban Indigenous Health, and also around systems thinking during the pandemic. And so I sit on the Communicable Diseases Network of Australia, which is the committee that really has set every single policy in the country, everything from masks in the very early days to distance to workplaces to airlines to marine shipping and overseas containers and freight ships and quarantine and testing in quarantine and post-quarantine testing, which is what we're doing right now. And really, that committee has taken me away from my primary aim of research, which is other infectious disease, and so much so that we've had 400 meetings in the last 18 months or so of that committee alone, which are often, they used to be 7 days a week, 5 days a week, and now we're at 3 days or 2 days a week now with CDNA. I also sit on the Aboriginal and Torres Strait Islander National Task Force for COVID. And basically, I think that those two committees have helped with the outstanding results we've had with COVID in our Aboriginal and Torres Strait Islander community. They're two committees, but actually people on the ground have done a lot of work to prevent catastrophe occurring in our communities with COVID over the last little while. So I want to touch on some of the outcomes among Aboriginal and Torres Strait Islander peoples here in Australia, but also more broadly among New Zealanders, Canada and the United States as Indigenous populations in those three respective countries. And then also talk about vaccine uptake for us as Aboriginal and Torres Strait Islander people, but also the other three countries as well. And then delivering on a roadmap from here and what we possibly could do from here on inwards. So firstly, let me turn to notifications among Aboriginal and Torres Strait Islander peoples. And this is from last year to this year. And we've hardly had any cases for the last 5 years, or actually the last week we've had some cases in the Sydney outbreak, so 5 cases in the Sydney outbreak in the last week or so. But actually what we can see here is a very small number of cases in total, 150 cases in the Aboriginal population, Aboriginal and Torres Strait Islander population. No deaths in the Aboriginal and Torres Strait Islander population. We're almost hitting 1,000 deaths in the non-Aboriginal population, and a population rate of diagnoses of COVID around 6 times less than that of non-Indigenous population. So really quite an outstanding effort to keep COVID out of Aboriginal and Torres Strait Islander populations and communities nationally. Never before in my life have I seen outstanding results like this in the communicable disease sector. And I'm going to talk a little bit about why that has happened, I think, with COVID and what's so different about this to other infectious diseases over the longer term, and what we might learn from this in later on down in the track. If you compare New Zealand Maori population, their rate, our rate per 100,000 is 19, and theirs is higher than ours. They've had 250 cases and 8% of all the cases. Ours is less than 1% of all cases, and they've had 5 deaths in the Maori population up until the end of June this year. I think most of you, or many of you, would have seen the devastating impact that COVID's had on. Where's my screen gone? I've lost my screen.
We can see it. We can see it, James.
Yeah,
James, you may be having internet problems, so just turn off your webcam and flick. You should be able to see your screen then. No good?
No.
Okay, I'm going to pull up your presentation from my end.
Okay, yep, no worries. Yep.
And you can keep going. Won't be a moment, everybody.
I'll put mine onto another screen, actually, if I could get that up. Yeah. Sorry about this.
So, James, what are we up to?
Keep going, the next one, the next one, and the next one, I think, 3 more. Yeah, that one. Yep. So I think most people would have, so if we get to, go back one slide, actually, yeah. So most people would have seen that or heard that American Indians and Alaskan Natives and Native Hawaiians are the 3 Indigenous groups in the United States. They are this yellow line here, and you can see of all identifiable populations that, thank you, I'm doing my own Zoom, my own scroll, but I realised it's not going to work here. You can see the yellow line there is really where American Indians, Alaskan Natives and Native Hawaiians have really been at the top of all identifiable populations in terms of cases throughout, and that was up until March or February, March this year. America started the vaccine program in December last year, and so you can see that the whole overall the vaccine program is having a good impact on the population cases, but there are still a huge number of cases in America day by day. The next slide. And this slide here is the number of deaths and a population rate of the deaths in American Indians and Alaskan Natives. Again, it's still the yellow line here, but actually you can see American Indians, Alaskan Natives and Native Hawaiians really were significantly impacted by COVID in terms of deaths, more so than any other identifiable population. Next. And in Canada, First Nations peoples in Canada's, there's been 32,000 cases of COVID among First Nations peoples. Many of those have occurred on First Nations reservations in the central prairie provinces of Canada and in the north. And if you compare that to Australia and New Zealand, where we've had 150 cases in Australia and 250 cases in New Zealand, that's a fairly big number of cases compared to our population. They've still got to have very active cases and still many people hospitalised, but they've had 357 deaths among First Nations people. That was up until the end of June as well. These figures are available from Indigenous Services Canada, which I've been in contact with. So really, it appears that we've dodged a very big bullet in terms of Aboriginal and Torres Strait Islander peoples in preventing COVID, but we do have a long way to go, given that at some point in time our borders will open up and we'll be very susceptible to new outbreaks. So next. So I just want to turn now to vaccine uptake and coverage among the populations. And firstly, I'll just talk about the Aboriginal and Torres Strait Islander population. So the data I'm about to present comes from the AIR register, so the Australian Immunisation Register, and most of the data was up until almost the end of June, and numerators and denominators are from AIR and the ABS, estimated resident population. So next. So in terms of vaccine numbers, this is the Aboriginal, so the top line is the, so this whole chart is for Aboriginal vaccine for people over the age of 50, and under 50 is the blue line. And you can see did a pretty good job once we had some vaccines available for our population, particularly once they started going out to Aboriginal community controlled health services. There's a fairly steep uptick in the number of notifications, but you can see the last 3 or 4 weeks, and actually up until last week as well, the number of cases have really, the number of people who have taken up their first dose of vaccine have significantly dropped off. And so here lays the big challenge for us, is to turn around this, because what we actually need to see is these charts continually escalating. I guess the last 4 weeks have been a bit tainted in terms of messaging and in terms of different advice that's been rolled out and by different people, some not medical, and this is kind of playing out in communities' hesitancy or complacency to take up vaccines. So he lays in some challenges to turn the over 50s chart around a little bit more and continue to get under 50s vaccinated and not have any of these dips that are occurring right now in our population. Next. And so this is this side here. I didn't have the non-Indigenous population, but this was from a week ago, but this is the data from today here. And so basically almost 100,000, we'll probably get to 100,000 this week, of Aboriginal and Torres Strait Islander people have had their first dose of vaccine. And that accounts to about 18% of the total Aboriginal and Torres Strait Islander population who are eligible for vaccines at present. Around, that excludes all the children under the age of 16, they're not eligible. And this figure here is the figure of people who have had their second dose. So 18% have had their first dose and 5% have had their second dose, which is understandable given the program's probably been going for about 3 months, and the majority of these cases who've had their first dose were AstraZeneca, and the recommended time to have your second dose for AstraZeneca is 3 months. So hopefully we'll see this figure here tick up very soon now that the 3 months is starting to occur for a lot of people. And actually in this last week, there've been a big number of cases of people taking up their second dose. So I think we will start to see some changes in the lag between first and second doses. Pfizer's a bit different. 32,000 have had their first dose, and actually Pfizer's only been available for the last month or so. But we should see this gap closing. So about half of the people have had their second dose of people who have had their first dose. So we should start to see that happening. But as more and more people go into the program, we'll probably see this differential all the way through. So next slide. But one thing to say here is that we're about half the rate of vaccine uptake compared to non-Aboriginal population. I guess that also needs to be amended, and it's probably related to that drop-off in overall vaccine uptake in our population in the last few weeks. Next slide, sorry. This is a slide from a week ago, and it's actually, this data is a little bit difficult to grab hold of. If you just push on the next button, it'll show you where we've got greatest coverage. So population coverage is of the eligible population when I say population coverage, it means of the eligible population, how many of them have had their first dose and their second dose here. And so in our population, you can see 26% of eligible people in the age group 50 to 59, 60 to 69, and our elders, actually all of our elders, you can see really great first dose coverage for the eligible population in our population. And as I said before, this should start to correct fairly soon once these start to get more close to complete with our second doses. But really, it's great that almost 60% of people over the age of 70 have had their first dose, and close to 40% have had in the 60 to 69. And these ones are obviously lower because they're not kind of included, or they haven't been included in the advice up to date yet, although the Prime Minister says anyone under the age of 40 who wants to get AstraZeneca should. So we might see some changes there, but actually these are the populations that have been recommended up until now, but we do have good coverage. And it's good that our elders have been leading the way and that we've got good coverage in the elders. One thing is there is a small risk with these vaccines, as you've heard from AstraZeneca, the risk of vaccine far outweigh the risk of not having a vaccine in these age groups here. Worldwide, COVID-19 has affected and the frail, overwhelmingly. And so if you get COVID and you're over the age of 60 or so, it's you've got a 14% chance of dying, which is a fairly high risk compared to less than 1 in a million chance of having one of the side effects from AstraZeneca, which have been widely reported. So next slide there. And this one is here by jurisdiction, and this is from a week ago. I wasn't able to get the data from a week ago, from this week. But you can see 10% of Queensland Aboriginal and Torres Strait Islander people, or 11%, have had their first dose, and not tracking too bad compared to the other jurisdictions, except for Victoria. So if you just press next, it'll come a red slider in there. But Victoria have had 36% of their population, 36% of the adult Aboriginal population in Victoria have had their first dose. And it's not surprising, given that Victoria has been most impacted by COVID, and there was a really big swing in vaccine uptake during the last lockdown in Victoria just a few months back. And that's where a lot of Aboriginal people got their vaccine. But yeah, so almost 28,000 people, it's much higher now, probably another 7,000 or 8,000 have had their vaccine. And so because the lockdown happened and people they had much greater capacity to roll out the vaccines in Victoria during that last lockdown, you can see Victoria, despite their population, the size of their overall population, a fair whack of them have had their vaccine. And if you think about Queensland, we've got a fair way to go in terms of our population vaccine to be taken. And again, this drop-off here is largely related to the gap between the two vaccines. Okay, next slide. So overall, by cities and regional and remote, you can see the coverage for Aboriginal and Torres Strait Islander population, the coverage of non-Aboriginal population, slightly lower across all regions in Australia. But once we get more vaccine out to these regions, I think we'll start to catch up with our population and the non-Aboriginal population. And hopefully we might overtake the non-Aboriginal population if we've got best practice in place over the next little while. But that will take good citizenship and good community and good communication for us to be able to do that. Next. And sorry if there's a lot of data here, but I thought it was really, you never see this data. And so I think it's really useful to talk through this data. So this is the proportion of Aboriginal and Torres Strait Islander people by age group who've had their first dose and received their second dose, and who are overdue for their second dose. So quite a lot of our population are overdue for their second dose of AstraZeneca and Pfizer. AstraZeneca here, and we probably need to address this, and maybe ATAGI, the Australian Therapeutic Administration Goods, going to make some recommendations about mixed dosing, hopefully with AstraZeneca and Pfizer. If you've had your first dose of AstraZeneca, they may be soon recommending Pfizer as a second dose, as other countries have done around the world, particularly in Germany. So yeah, a lot of people overdue for their second dose, so it will be a job for primary healthcare services to chase up people over the next little while to make sure that people are fully covered from both vaccines. Next slide. And this is the Pfizer, people who are overdue with their second dose with Pfizer. So AstraZeneca has got a 3-month recommendation between your first and your second dose. And there are, of the 10,000 people who've received of the 23,000, there's 617 people who are overdue for their second dose in the Aboriginal and Torres Strait Islander population. So we've still got even with people who've got a 2-week break, there are people overdue for their Pfizer dose. So we probably need to watch that as we move forward with the rollout of the program. Next. Yeah, just to think. Now this is an interesting. Anybody can go onto this website here called AusVac Safety. It's open, and you can get this data here, and it's a really useful data to allay communities' fear. It's really useful data to allay communities' fears about the vaccines. So go onto AusVac Safety, You can see here, what happens here is people can submit a survey after they've had their vaccines about their side effects. And so 1 million people have been sent, and more than 1 million people have now completed Ausvax Safety. And 15,000 surveys have been completed for Aboriginal and Torres Strait Islander people, which is a 73% response rate, which is higher than the response rate in the non-Aboriginal population. And the next slide shows the difference in the two populations. So for people who say they've had no adverse events from Pfizer, it's very, so overall, Pfizer 62%, and for Aboriginal and Torres Strait Islander people, what have we got here? Less people have had side effects in the Aboriginal and Torres Strait Islander population than non-Aboriginal people, and the same for AstraZeneca. More people in the Aboriginal and Torres Strait Islander people have had less side effects for AstraZeneca. So not very much difference there between the two populations. So next. So I'm just going to turn now to what's happened in America with the vaccines here. So like the slides before showed, the American Indian and Alaskan Natives were the highest in cases and in deaths. American Indians and Alaskan Natives are now highest in vaccine rollout, and they have been for their first dose and for their fully vaccinated doses, so their second dose as well, which is great news and has had some really good impact, as you could see from the slide before, where the number of cases had dropped significantly in the population. So next slide. For Canada. Oh no, so this is just some news articles that have been recently shown. So some of the communities, some of the reservations in America were really kind of, this community here, quite a small community, 500 people, 50 deaths in that community, but you can imagine that with any community in Australia, an Aboriginal community. 98% of the citizens that are there now fully vaccinated, and 60% in Navajo Nation, which is a really big nation in the United States. 60% are fully vaccinated, and America is about 40 to 50% fully vaccinated at the moment. So really, although these two communities were kind of severely impacted by COVID-19, they've really taken up to the vaccine in their population. So really, they should see very few deaths now from COVID-19 in their populations now that most of their population are vaccinated. Next. And from Canada, again, this is the number of cases in Canada, and so they peaked in January this year. They really were on the escalation, and at the same time, they really got vaccines out to First Nations communities, and you can see the impact of number of cases once the vaccine started to roll in, combined with restrictions which we all face when there's big movement. So there was restrictions in movements and masks and space and so forth as well. So this is in the middle of their winter. And you can see once they start to get the vaccines out, the number of cases start to drop off big time. And so it's really a nice chart to display to communities who might be have some reservations about vaccines in our communities. Next. And so the really big difference here is that 687 communities in Canada have the vaccine available to them, and the number of steeply increased. And on reservation in Canada, 75% of First Nations have had their first vaccine. So that's really an incredible number, and what we should be aiming for in Australia, 75% and above, I think, for to prevent deaths in our communities. Next. And then from New Zealand, they started just a little bit later than us, a week later than us, but 8% of Maori have had their first dose, and almost 5% have had their second dose. But you can see we're up to 99,000. So they started a bit later than us, but they're up to 61,000 have had their first dose. So a little bit slower than us, but and I'm confident this mob will get it as well as we do, or hopefully they increase their numbers substantially over the next while, because they had 250 cases, we're still at 150. They had 5 deaths, we've had 0 deaths. So it's pretty important we try and promote the vaccines as much as possible. Next. So the summary of the COVID vaccine program so far for us, for Aboriginal and Torres Strait Islander people. The gaps in coverage are a little bit less for Aboriginal and Torres Strait Islander people, except in age groups, the older age groups. We've got similar coverage in older age groups, which is great for us. The coverage gap is similar by region, by urban, regional areas and remote areas in all states except for Victoria, which has got really good coverage for Aboriginal and Torres Strait Islander people. There's no difference in adverse events reported for both vaccines, but as I showed before, there have been some recent declines in vaccines administered to our population over the last 3 or 4 weeks, which is a bit of a worry for us. Next. So thinking about our vaccine uptake so far, so there's a whole range of reasons why people may choose not to take up vaccines, but some of it's driven by social, cultural and political views. Why us, I've heard, why we're the guinea pigs, mistrust with healthcare systems, previous policies, why are we first? You know, a whole range of those issues come into it. I think some of it might be a victim of our own success. We haven't seen cases or deaths like the rest of the comparable countries have. I think this is a bit of a problem for many of our population navigating booking systems. I think lack of confidence in the vaccine and social media. People read a lot of social media in our population. Changes in advice, which probably dampens people's enthusiasm, plus deterred our own communities from developing our own messages. I think that definitely. Lack of culturally safe places as well as convenient places to receive vaccines. So people lining up for ages and big lines, and people not willing to do that. And many of the AMSs haven't got Pfizer. A lot of them had AstraZeneca, but during July, around 130 of the Aboriginal medical services nationally have registered to receive Pfizer, and they should all start to receive it towards the end of July, some Pfizer, and from there on inwards, there'll be dispatches going out to general practice and to Aboriginal community-controlled health services over the next little while as the supply comes more available over the next 6 months. But also, I think one of the other things that plays into it is we've got a much younger population than the non-Aboriginal population. And I think our population, well, young people have always been told you're not at great risk of COVID-19. And I think this plays into vaccine uptake in our population. So it's great our elders are taking up the vaccine, but we also need our whole population to take it up when they are eligible for vaccine there. So just in closing, ATOs, I think, were some of the first general practices to be given access to Pfizer, and they achieved really good results with the over 50-year-olds. They've got very similar coverage of Pfizer to general practice clinics. So the more we can get it out to both sectors, I think the better off our population will be. Next. And as I said before, the AMSs will start to increase it over time. And next. So what I think we absolutely need to do here is continue the partnerships that have been the cornerstone of the whole pandemic approach. and response since the pandemic. I think we absolutely need to do much more with messaging, and this is where PHNs can have a very good role in this. I think, you know, even in Queensland, our lockdown last week, I saw a lot of social media from our mob saying, if you're vaccinated, do you need to wear masks? Or if you're vaccinated, do you still have to quarantine? Do you have to isolate? Of course you do. But I think we need much more transparency around what the vaccine does. So it prevents serious complications and hospitalisations. It won't stop you from getting COVID into the future, and I don't think that's been explicitly stated. And I think we absolutely need to do our own messaging with Aboriginal and Torres Strait Islander people about these kind of messages, because our people are interested in COVID. They don't want to get COVID, but I think there's some hesitancy, and I think the more transparent we are, the better off we'll be in terms of rolling out coverage. I think we absolutely need the champions, and I've seen a lot of social media with Aboriginal leaders and CEOs and organisations rolling up their sleeves to get their vaccine. But I think community-led interventions will be the answer to increasing vaccine coverage in our population over the next little while, because we absolutely need to do it. COVID's not going away anywhere, and we all need to be vaccinated. And the sooner people recognise that, the better off we'll all be, I think. So finally, it's a long road ahead, but I think one that we can lead the rest of Australia out of. I think if Indigenous Australia, I saw this great story from Maningrida, one of the remote communities in the north of Australia, yesterday, where the vaccine team were flown out to Maningrida. I had a lot of community consultation beforehand. 1,400 people in Maningrida were vaccinated over 3 or 4 days, and I think those kind of stories will lead Australia out of the pandemic, and particularly for our population. The more we see those kind of stories, the better off we'll be. And so I might leave it there. I think that's the last slide, and open it up for questions. But again, I'm optimistic we can get out of this. Canada, the United States have really shown the way, and I think we can do it as well with our population. There is one more slide with just a whole lot of photos of people rolling up their sleeves to get the vaccine, some of our major leaders in the country, and really great to see this. So if you're doing vaccine clinics, make sure you get the leaders to put their faces up there and put it on posters even, and put some snappy health promotion messages around it. So thanks very much.
Thank you very much, James. Now, could you please, everybody can go and put your questions in the chat line for us, and Jody will read them out to James as they come through. Thank you very much, James. Very, very good presentation and vital information.
Thank you. Sorry, there's a lot of data in there, but actually I had to get a lot of permission to present that data. So it's probably the first time you can see that data, and now it's been presented, you'll have access to it. So one thing we haven't done very well with our response is to get the data out very efficiently. I can go onto Canada and the United States and New Zealand's Ministry of Health's websites and access all the data. And that's what I did actually, but we haven't quite got to that point in Australia yet, but we are hopefully working on that very soon.
Thanks, James. Over to Jody for the questions.
Thanks, Patty. I can see that people are writing questions in right now, so I'm just having a look at those. Lots of compliments, James, on your presentation, so thank you very much.
Thank you.
Just seeing what's coming in. I can see that people are typing, so we're just going to have to wait a moment while they come in.
And James, I know that Western Queensland PHN has done a great campaign on "Don't listen to the gibber, go see a jabber," which is going really well. So I think there's some and that was done by, you know, the Aboriginal and Torres Strait Islander group out there, and Sandy Gillies, our CEO out there, is an Aboriginal woman. And so it's, as you say, those messages are so important coming from our First Nations people.
Oh, that's fantastic. Yeah, I know, Sandy, that's very good. Yeah.
James, I've got one question that's come in, and it's around the Pitjantjatjara advice about mixing doses. So is that something that we expect to happen sooner rather than later? Have you got any inside information around that?
I think now that other countries are rolling that vaccine schedule out, Target are definitely looking at it, and maybe in the next week or so, or we should hear, if not beforehand, about their deliberations on that. So watch that space, because I think it will make a big difference to people who are overdue for their second dose of AstraZeneca. That might,
Sure. And what are your thoughts around encouraging people that are now vaccine hesitant after having had their first dose of AZ to encourage them to get the second? What messaging should we be doing?
Yeah, so they're only partially covered with one dose, so it's not that effective if you've only got one dose of the vaccine. So I'd really encourage strongly to either to go and see your next dose. The risk of the thrombocytopenia, the platelets and the clots is so minimal, but if you acquire COVID and you're in an older age group, the chances of you being hospitalized, ventilated, in ICU are much, much higher than the risk of a clotting event, as we've heard about. And unfortunately, our media seem to grab hold of it. It is unfortunate that we have these incidents, 1 in a million or of these incidents occurring, but the risks are the benefits of vaccine far outweigh the risks of not being vaccinated. And the reality is COVID is not going away. It is a global pandemic. We're going to need vaccines into the long term. Whether I don't know what that's going to look like, or whether we need a booster like we have with flu shots every year, or a different strain, a different vaccine every year to the different variants that are occurring. But we are going to need vaccines in the longer term. It's here forever. It's not going away anywhere. So you might as well get on board as soon as possible. If you're hesitant about it, I'd really strongly encourage people to take it up.
Thanks, James. I've got another question. What contributed to the success in keeping COVID infections out of Indigenous communities, do you think?
Yeah, I think it was early. It was much earlier pandemic response. There was clear pandemic governance, so communications, services, leadership, and you know, some of the other restrictions that were put in place, which communities weren't that keen on. You know, when borders were closed and discrete communities were locked down, it probably gave us some time to think about, well, what do we need to do here? There were so many things happening around that time in March and April and May last year, which was really the hectic time. But all of those things, the Aboriginal leadership came together. I think where the Aboriginal leadership sat within the Commonwealth, the kind of pandemic response. So NACCHO and the Aboriginal Task Force, the chairs of that, were the Department of Health and NACCHO, had direct feed into the AHPPC, which is all the Chief Health Officers, all the Jeanette Youngs. They fed directly into that committee, and that committee fed directly into the National Cabinet. So pretty high level status for Indigenous communities. Basically, we identified many issues that became available, whether it be many communities had no places for isolating people if there was a pandemic. Many communities, it would take 5 days to get a COVID test result back. We rolled out 87 point of care machines in that period. There were lots of issues identified. We closed down borders and we closed down communities, and you know, there were delays in opening back up communities, especially when the rest of the community occurred, but it was kind of legislation that needed to be changed to undo that. And so I think all of those things helped. Leadership, pandemic response very early, some champions around the place, agile government processes, and really what happened was the leadership from Aboriginal communities. So there's about 40 people on the Aboriginal task force, and everywhere from the Kimberley to the south of WA to the north of Queensland, we had representation from all over the country, and communities kept on identifying issues, whether it be the surge workforce was cut off because there were border restrictions in communities. We had to deal with every single thing that jumped in front of us for the Aboriginal task force, and yeah, and fortunately the government system was very agile during that period and has enabled the success we've seen in our communities.
Thank you. Do you have any recommendations on how to address vaccine concerns or hesitancy amongst Indigenous clinical staff?
Not really. The aged care sector is a really, you know, when you see only a third of the aged care sector have had their fully vaccinated, it's a bit of an issue given they were the first priority population off the rank. I have no advice except for clinical staff to be more averse with reading up on the data around vaccine effectiveness and safety. And, you know, if our clinicians are not getting it, it makes it very difficult for them to sell the story to the population they're serving. Yeah, I'm not sure what's going to happen into the future with that. You can't, it's funny, some clinicians, you know, most clinicians have to have a Hep B vaccine or a TB swab before they start their employment. But COVID, we haven't gone down that path, and is mandatory, as you know, but we haven't gone down that path with COVID, but maybe that will be something that has to happen into the future.
Yeah, we've just had a question or a statement come in from someone asking your view around, you know, making COVID vaccine mandatory for all populations. Yeah, I guess that's a work in progress. We'll see what happens.
Yeah. I mean, we get 80% of the population vaccinated. We're going to see big, much greater protection for the Australian community. As I said before, if the borders open, we're going to be susceptible to major outbreaks in communities. And we see major outbreaks now with a small number of our population vaccinated. And those people are going to end up in hospital. A fair whack of them will end up in hospital, and they'll need to be ventilated. And that's a major concern for the hospital system. It blocks up the hospital system with COVID alone. Fortunately, during COVID, when we had all those other restrictions, we had very low influenza rates. If we had the double whammy in future years of influenza and COVID, we're going to be in big trouble in the hospital system. We won't be able to do it, and we'll have to open up, temporary hospitals in fields like they had to do in New York City, for instance, where they had big influenza and COVID simultaneous infections. We had one of our lowest influenza seasons last year of last 20 years. And partly that was because of lockdown and restrictions and masks. But in the future, if we have COVID and influenza, it will totally block our hospital system up. And that's what we need to avoid into the future.
I've got another question. Do you think we would benefit from a national advertising campaign specific to our First Nations people?
I think so. I think if it's done with lots of consultation and lots of and the right approach. I mean, the messaging for remote communities probably needs to be a little bit nuanced compared to urban communities. Yeah, I think they help. I always kind of say in health promotion, you absolutely need some overarching campaigns, but you absolutely need local campaigns as well. And things like the don't listen to the gibber and go and see your jabber. Those kind of campaigns with local talent and local people involved and local messaging are going to be much more effective. But a national campaign I wouldn't say no to, but to reinforce what the national campaign is, you need local campaigns as well. Yeah.
James, are you happy for your presentation to be shared today?
Yeah, absolutely. Yep.
Okay, thanks. So the PHN will send out a recording of this webinar, and we'll also send out the PowerPoint presentation. Thank you.
Great, thank you. Thanks so much.
So James, no more questions, and I'd just like to say a very special thank you to you for your time today, and I hope that everyone online has found it as beneficial as I did with all of that information, and help us all to go out and spread the word of how important it is for our First Nations people to get vaccinated to keep their families and communities safe. So have a wonderful rest of the week, and stay safe and well.
Yep. Happy NAIDOC. Thank you.
Happy
Happy
NAIDOC.
NAIDOC.
Yep.